moving on, PPARs. So stage setting question. Which of the following about PPAR-based therapies is correct? PPAR alpha improves insulin sensitivity. PPAR gamma acts principally on adipose tissue to reduce lipolysis. PPAR gamma has potential for causing anemia. And PPAR gamma agonists increase spontaneous femur fractures. Can we have the question, please? Okay, so we will see. Let's look at the data. So we'll start with something that you're all familiar with, which is that there are many comorbidities, and they are all linked to metabolic stress, which historically we have measured by insulin resistance as a surrogate marker. In this setting, PPAR gamma acts both in adipose tissue and in the liver itself. In the adipose tissue, it improves insulin sensitivity, and as a result, it increases, and it does this by increasing adiponectin. Adiponectin is also a target for FGF21, so it shares that common with FGF21. And adiponectin then can affect the liver and produce benefits in the liver. Through its effects by improving adipose tissue insulin resistance, it also decreases the release of fatty acids from the adipose tissue. So there are two peripheral effects. One is adiponectin, the other is reduced fatty acid release. And by improving insulin sensitivity, when you take a food intake, it increases glucose clearance by striated muscle, so there is less glucose available to the liver for de novo lipogenesis. Within the liver, it directly works on this transcriptional factor called PGC1 alpha, which affects mitogenesis. And mitochondria are at the heart of what causes the damage in NASH. Because when you stress your metabolic machinery, you produce oxidative stress. It damages the mitochondria, and the mitochondria are the primary source of oxidative stress. So you accumulate this sick mitochondria in NASH, and what this does is it allows you to generate new healthy mitochondria, and so thereby reduces oxidative stress, which also has anti-inflammatory and then anti-fibrotic benefits. So it has both effects in the liver, which are different than the effects in the periphery. So we've already seen the data with pioglitazone, so I'm not going to waste any time, but I will make one point over here. If you look at the proportion of people who had a one-stage improvement or greater of fibrosis with pioglitazone or vitamin E, the green bars are the vitamin E. What you see over here is that the numbers are, the proportion is a little bit higher. Now, in the original PIVENS trial, the study was not powered for fibrosis. So for this effect size, there was no p-value. But if we had if we had 140 patients in each arm, this would have been statistically significant. So there is some evidence that it does improve fibrosis to some small effect, but so does pioglitazone. Now, you already have Saroglitazar, and I think the next talk is on Saroglitazar. So I'm not going to waste too much time over here, except maybe to talk about the basic science, which is that Saroglitazar improves key features of NASH in a preclinical model where it improved all the individual features. We published this in 2020. It reduces cell stress, which is unfolded protein response. It improves oxidative stress. And JUNK is a very important inflammatory pathway, and you can see that it completely shuts down the junk that is associated with Western diet. And it reduces smooth muscle actin, which is a marker of fibrogenesis. And this is also shown that it has a big footprint in terms of the immune inflammatory response. So not only does it have the conventional metabolic benefits, but actually cools off the inflammatory response in NASH as well. And it has been shown in early studies to improve ALT and also liver fat content in phase 2 trials. And glycemic parameters, I'm not going to, I didn't realize that, Ajay, you are going to give this talk, so I'm sorry I have these slides in here. So I'm going to go very quickly through this, and also to point out that it does actually, there's some early data now on histology as well, which I'm sure Ajay will cover. So what I'll jump to now is lanifibranor, which is actually not talked about a lot, but it is actually potentially, it could be a very important player. So there are 3 types of PPAR receptors, the PPAR alpha, PPAR gamma, and PPAR delta. And PPAR alpha predominantly increases fat oxidation. PPAR gamma is insulin sensitizing. And then PPAR delta is anti-inflammatory. So lanifibranor is a pan-PPAR, and PPARs are nuclear receptors. So it is a pan-PPAR, so it has all 3 effects. Now remember, there was another drug called elafibranor, which was also a PPAR alpha delta and had no effect. It's been taken out of, it's no longer in development. There was a drug which was a pure PPAR delta, seladelpar, but there was some concern about whether there was some hepatotoxicity. Turns out it didn't really matter, but that really has not going anywhere. So fenofibrate has been looked at, doesn't really work by itself. So you do need some PPAR gamma, and you need potentially, but PPAR gammas have some issues with pioglitazone. You get the weight gain, you have fluid retention, and you can even get some dilutional anemia. So people are looking at these combinations. So Lani is a pan-PPAR, and actually it has been shown to affect all of the different features of NASH. So here's the phase 2 trial that we published in New England Journal, where it looks at initially the SAF score, and you can see that over here, dose-dependent, statistically significant results in resolution of NASH. So the primary endpoint for this was the SAF score rather than a resolution of NASH, which is the regulatory endpoint. So I'm just showing you the regulatory endpoints. So you see a greater proportion, 44% in the ITT population and 51% in the per protocol population. Similarly, if you looked at improvement in fibrosis, significant. So this is the first drug that hit both NASH resolution and fibrosis improvement compared to placebo. And when you look at the combined endpoint, which is both resolution of NASH and fibrosis improvement, 1 out of 3 patients actually met this endpoint. So that's actually a pretty substantial step up from where we were previously in terms of generating high-quality evidence to show that something actually works. So lanifibranor is currently in phase 3 trials, and it's called the NATIVE trial, and it is moving forward around the world. I don't know if this is in India, if Lani is I don't think India is part of this phase 3 trial, but I would keep an eye on lanifibranor within the PPAR space. Saroglitazar, which you'll hear about in detail, which you already have here and is approved. That and I think lanifibranor are going to be important players. But what is very encouraging to me is that it tells us that our therapeutic armamentarium is growing. You heard about the antifibrotic benefits of OCA, the major benefits of GLPs. Now you're going to hear, you've heard now about lanifibranor, and now you're going to hear about saroglitazar. So with that, I think I'll turn this over to Ajay.